Hi and welcome to this podcast on diagnosis and management of recurrent nevus. Recurrent nevus, also called persisting nevus or pseudomelanoma, is a benign melanocytic nevus with regrow after incomplete surgical excision or trauma. It usually affects young individuals and often reveals a history of shaving biopsy, laser treatment, or trauma. The pathogenetic mechanism is largely unknown, but activation of melanocytes is suggested. Clinically, a bizarre area of hyperpigmentation within an elevated nevus or an area of a scar can be seen. These bizarre areas of hyperpigmentation show up on dermoscopy diffuse brown to black globules, streaks, or thick lines. Here's an example of a recurrent nevus after incomplete shaving biopsy. Bizarre and irregularly arranged globules and streaks are seen. Another example of recurrent nevus after incomplete laser removal, which, by the way, and as a general rule, should be never performed on melanocytic lesions. In this case, irregular lines, globules, and heterogeneous pigmentation in a centrifugal arrangement is seen. In this case, there is a repigmentation in a small intradermal nevus. The area of pigmentation is composed by centrifugally arranged irregular globules and dots. The central area of repigmentation is often seen around the hair follicle, like in this case. The most important differential diagnosis of recurrent nevi includes recurrent melanoma. Time of occurrence of the pigmentation after injury, distribution of pigmentation within the scar, and evaluation of dermoscopic structures are clue parameters that aid the correct classification of the lesion. Regarding the time of repigmentation, a quick repigmentation after few weeks to months is in strong favor for recurrent nevus. Instead, recurrent melanoma usually show a slow repigmentation, often months or even years after the excision. Recurrent nevi show a repigmentation confined or within the center of the scar. Instead, repigmentation beyond the scar's edge and extension to the normal skin are more commonly observed in recurrent melanoma. Centrifugal growth pattern within the scar, composed by irregular globules and streaks, are also in favor of a recurrent nevus. Instead, a non-continuous growth pattern outside the scar, often showing diffuse pigmentation or network, is more commonly seen in recurrent melanoma. Here we have a side-by-side comparison between a recurrent nevus on the left side and recurrent melanoma on the right side. For the recurrent nevus, the repigmentation just started 1 month after the surgical intervention, and this short time is strongly in favor of a recurrent nevus. Instead, there is a tiny focus that developed 8 months after the primary excision of the melanoma, where we can see the scar. And this is more suggestive of recurrent melanoma. Dermoscopically, in the case of recurrent nevus on the left side, we see the hyperpigmentation within and confined to the scar. It shows a globular pattern, and again, this is more suggestive of recurrent nevus. Instead, in the case of the recurrent melanoma, we see the pigmentation outside the scar on normal skin. And again, this is more in favor of recurrent melanoma. Regarding the management, some words should be spelled. Recurrent nevi are also called pseudomelanomas because they can mimic melanoma both clinically and dermoscopically, but also histopathologically. If a previous histopathologic confirmation of a nevus is available, and if the clinical features are compatible with the diagnosis of a recurrent nevus, usually no further treatment is warranted. However, if no previous histopathologic diagnosis is available, or if the clinical and dermoscopic features are controversial, complete accession is mandatory and eventual revision of the original histopathologic slides should be requested. Given the difficult morphology upon pathology, pathologists should be provided with all important clinical information, including the clinical suspect, the age of the patient, and eventual previous history of trauma or surgical cosmetic procedures.